Okay, I think we can start. Not many people like the previous one, but for you guys to know that the presentation is streamed live on YouTube. So if the room is full and somebody asks you to attend, they can watch it live on YouTube and you can ask questions at the same time. They can ask on Telegram, on WhatsApp, and also on YouTube. They can ask questions whichever they can. So today's talk is a mix of neonatology and pediatric, and it's about use of antibiotics and the reason for antibiotics. The antibiotics can save life, but at the same time can be harmful if not used appropriately, and hence the reason for this presentation. So let me share my screen. People keep coming. The number is increasing. So let me share the screen. And please remember to mute yourself. Okay, and people still keep coming. They come late. Okay. And if please mute yourself. Okay, so the objectives of this talk is to give you some introduction, and then we'll talk about mechanism of actions of different antibiotics, and then we'll speak about selective antibiotics such as Betalactam, Carbapenem, Monibactam, Aminoglycoside, Macrolides, and also we'll talk about other antibiotics. And if you can kindly mute yourself. Okay. And other antibiotics, and then we'll talk about how to select antibiotics, and we'll give some words about Lumnia. Please mute yourself. And we'll talk about the stewardship. Okay, so you have to know before we start. Lumnia, please mute yourself.
Okay.
So there are two types of antibiotics. There is bactericidals, which kills the bacteria and lead to death. And there is bacteriostatic, which is either, both mechanism of action interfere with the growth. So it's either interfere with the immune system or arrest the growth. And therefore, if the bacteria is not growing, it cannot multiply, and they eventually die. Let's speak about very common antibiotics and how they work. We have the antibiotics that inhibit cell wall synthesis. An example of that, the Penicillin and Cephalosporin, Carbinum, Monobactam, and Vancomycin. And if you can kindly, Kaguga, if you can mute yourself, please. And vancomycin, they all work by inhibit the cell wall synthesis. And we have the antibiotics that inhibit the synthesis of a protein through either 50 subunit or the 30 subunit. An example of antibiotics that inhibit the 50 subunit is the macrolides, clindamycin, and linezolid. Those inhibit 30 subunit is aminoglycoside and tetracycline. There are other antibiotics who inhibit the DNA either through the folate or interfere with the, can you please mute yourself? Yeah, Shada, please mute yourself. inhibit nucleic acid synthesis or function. So those inhibit folate synthesis, example, trimethoprim and sulfamethoxazole. And those inhibit the DNA gyrase, such as quinolones and ciprofloxacin. And those reduce the contact of antibiotics with free radicals. And example of that is the metronidazole. Can you please mute yourself? Okay. So let's speak about the beta-lactams. The beta-lactam example, benzathine penicillin, penicillin G, penicillin V. So benzathine penicillin is a long-acting. Fatma, please mute yourself. Dr. Fatma. Please mute yourself, ya Fatma. Dr. Fatma, I muted you 6 times and then you open it again. Okay, so penicillin example, benzathine penicillin, which is long-acting penicillin, and usually we give it very infrequent dose. And we have the penicillin G, we give it oral, and it's mainly active against streptococcus. We have penicillin V, we give it IV. We have the ampicillin and amoxicillin, and broad-spectrum antibiotics with both gram-negative and gram-positive, more gram-positive. And amoxicillin is better to be oral, and it's a little bit longer of action. We have amoxicillin clavulinate, and the very common example is the augmentin, which decrease the resistance against ampicillin. We have the nafcicillin, oxacillin, and floxacillin, which is against the staph, but the MESA type of staph, not the MRSA. We have the piperacillin and ticarcillin, which is yeah, Dr. iPhone, please mute yourself. The piperacillin and ticarcillin, it's more against Pseudomonas, and also it action against staph, but it acts against MRSA, not only the MERSA. And the piperacillin tazobactam or piptazo, it's a more wide spectrum and has very good coverage of gram-negative. And we have the cephalosporin, and the cephalosporin, we have the 5th generation. We have the 1st generation, which is more example, is cefazolin and cephalexin. And cefazolin is more coverage of strep and also cover the staph, but it only cover the MERSA. We have the cefazolin, which is the IV, and cephalexin, which is the oral. We have also the 2nd generation. We have example cefoxitin, which is IV, and cefotitan, which is IV and IM, and you have cefuroxime, which is PO, and cefaclor, which is PO. The 2nd generation has more coverage of gram-negative, and it covers also gram-positive. And we have oral, and it's a little bit longer action. The 3rd generation, it become more gram-negative than gram-positive. An example of ceftriaxone, which is a little bit longer action. And we have the common cefotoxime, and we have the ceftazidime. And ceftazidime also covers it, but it also covers the Pseudomonas. And we have the cefpodoxime, another example of the 3rd generation. And we have the cefdinir. We have the 4th generation, which is the most common, is cefibime, and it's become more coverage of gram-negative rather than gram-positive, and it also covers the Pseudomonas. And we have the 5th generation, that are very good coverage. Example of the Cephalosporin, which is cover also the Pseudomonas. Example of beta-lactam, please the iPhone, mute yourself. We have the Carbabinum, an example on the Meropenem, the more common. And the most common problem facing the Meropenem is the overuse. And people, and I hate this word, upgrading antibiotics. You know, I really hate the word, but people are using, and we have, having increasing resistance to against Meropenem. And other example, Dr. Albana, if you can mute yourself, or Alban. We have the Etrabinum and Imibinum. The difference between Meropenem and Etrabinum, this have more CNS side effect. So Meropenem has more side effect, and if we have one, we can use instead the Imibinum. Dr. Albana, please mute yourself. And Dr. Shakir. Okay, and we have the monobactam example, the Asthrionum, the Asthronium. So let's speak about the penicillin. The first penicillin is benzathine penicillin. It's a long-acting. We give it IM, and we give it, for example, as a prophylaxis in rheumatic fever, and usually we give it 1 dose. Or we can give it 1 dose every week or every 2 weeks, and even every 1 month. We have the penicillin G, there is IM and IV, and we have the penicillin V, which is oral. These are very good coverage of streptococcus. So if you have streptococcus, whether it's group A or group B, it's a very good coverage. So for example, if you have a, you did sepsis workup in neonate, for neonate, when you start ampicillin and gentamicin, and if the cultures after 48 hours comes to be positive for GPS, then it's better to switch to the penicillin G, because it have very good coverage. However, both are not broad spectrum. So if they are not good choice for as a first choice as a broad spectrum antibiotics. I am selecting Dr. Salma. I'm selecting mute everybody, but they open it. So I know I already muted everybody, and not only 1 time, many times. But again, they open it. So if they put option on the entrance that do not mute myself, the system will open them. So the penicillin and the penicillin G is not a good choice for first or a guessing therapy. They're only good when you diagnose. Dr. Salma Soot, please mute yourself. So they are not good start, good guessing therapy. So what they work? They work for gram-positive, and they work for anaerobe. They work against group A and group B streptococci. They work against syphilis. They're very good against meningococcal meningitis and meningococcemia and periodontal infection. So whenever you have an oral infection, when there is oral infection, it's a good choice to use penicillin, whether IV or oral, depend. It's also good for prophylaxis of antibiotics, and it's also good for group A and group B if diagnosed, especially group B streptococcus in neonate. And it's very good against human and bite, and also animal bite. Ampicillin, which is IV, IM, and oral, and Amoxil, which is PO. They are very good coverage, gram-positive and gram-negative, more gram-positive, and they are very broad spectrum. So they are very good as a guessing or initial therapy. And so they have more gram-negative than the penicillin and benzathine penicillin. They are very good coverage against Listeria monocytogenes, and therefore it's a very good guessing therapy, and especially for neonatal sepsis. And they work as energistic. They work against enterococcus, And they're very good initial therapy for bacterial type of otitis media and also community-acquired pneumonia. And they work against E. coli, UTI, but because of the overuse of antibiotics, Dr. Hanin, please mute yourself. We're facing resistance to E. coli causing infection to the Amoxil. We have the potential decreasing resistance Amoxil, which is called Amoxil, Amoxicillin clavulanate, and it's oral, and the example of it is Augmentin.
Hello?
So what happened? It increased. Dr. Aisha, mute yourself.
Applying
Please.
for her.
Okay.
Mute all. Okay, so what it does, it increases beta-lactam inhibition. And it's very good for acute otitis media. And very good for sinusitis. It only works against staph massa, so methicillin sensitive staph aureus. It does not work against MRSA. And like the penicillin, it's a very good guessing therapy for animal bite because the most common bacterial animal bite is Pasteurella and staph aureus. However, if you know that the staph aureus is MRSA, amoxicillin is not. How you know?
Excuse me, Professor. We cannot see slides. We cannot see.
You cannot receive the slide.
Oh, you don't see the slide from the beginning?
No.
Yes.
No.
Oops.
We didn't see them.
Oops. Oh, that's not good.
I can see the slides.
You cannot see the slide. Why didn't you tell me?
But for me, I can see the slides.
Do you see now?
Yes.
Do we see
Yes,
all?
Yes,
Yes.
now I
Yes.
see.
We can.
Okay. Thank you. So Amoxil clavulanate is adding clavulanate to the Amoxil, and therefore it can be used oral. An example, it's Augmentin, and as I say, it inhibits the beta-lactam, and it's a very good guessing therapy. It's very good against otitis media, sinusitis, and MRSA, and therefore it's a good guessing therapy, starting initial therapy for animal bite. The other potential, we use ampicillin sulbactam, and it's the same of amoxicillin clavulanate, but this is an IV, and it can be IV and also can be used IM. Example is the Unacin. And so again, it increased beta-lactam inhibition, and because it covers the gram-negative and gram-positive, and it works against staph, but it's more work against MRSA, and it's good for soft tissue. Therefore, it's a very good choice for aspiration pneumonia and lung abscess and animal bite, and also community-acquired pneumonia if you cannot give oral. The other is Nafcicillin and Oxacillin. The Nafcicillin and Oxacillin are very good for MRSA, and they are very good penetrant of tissue, and therefore they are very good for osteomyelitis. They do not need vascularization and also inflammation. Increase their penetration. Therefore, they're very good choice for avascular lesions such as osteomyelitis, meningitis, and endocarditis. However, it should be MRSA, not MRSA. The other example is piperacillin and ticarcillin, and also piperacillin plus tazobactam, or what we call it beptazo. An example is the Zosyn. And the Zosyn are very good. The difference between the Nafcicillin and Oxacillin from piperacillin and ticarcillin, they have anti-Pseudomonas activity, and these have more gram-negative. And also they work against staph, but they can work against MRSA. So they are anti-Pseudomonas, They have extended gram-negative in addition to gram-positive. They work against Staph aureus, they work against anaerobes, and they are beautiful for abdominal abscess and abdominal infection, for example, immunology in neck. And they are also good for acute aspiration, like the Amoxicillin sulbactam. So one of the most common side effect or problem with using penicillin is allergy. And you have two types of allergy. We have the immunoglobulin E mediated, and usually it takes minutes. And this is cause sudden anaphylaxis, hypotension, bronchospasm, angioedema, and urticaria. And so therefore, any baby, even if there is no history of allergy and you want to give IV, probably it's better to give test dose. And if you want to give oral, then you can also give a small dose, wait a few hours before you start the medication. And in the hospital, and if you want to give it, you can give test dose. That takes about 1 hour to see the result. And this is have two benefits. The first is the checking and making sure there is no allergy. Second is can decrease the use of antibiotics. The second type of allergy is immunoglobulin G mediated, and usually takes days. And an example cause urticaria, fever, arthralgia, and arthritis. So you need to remember that when there is a rash associated with penicillin, but without itching, that does not mean allergy. It means there is side effect. All the drugs can cause skin rash. So when you don't have rash, but there is no allergy, no itching, no hypotension, no bronchospasm, no urticaria, no fever, only rash, especially if it's not itching, then probably you're not dealing with allergy, or you're dealing simply with some side effect of the medication. The second type is the cephalosporin, and we have the first generation. An example of the first generation, as we said, the cefazolin, which is the IV, and cephalexin, which is the oral. Second generation, we have the cefoxitin, cefotitan, and also we have the cefuroxime and cefaclor. We have the third generation. The most too common is ceftriaxone and cefotaxime, but also we have the ceftazidime and cefixime that use, and cefdinir using as a prophylaxis for surgery. And you have the fourth generation example is cefibim, and the fifth generation, the ceftaroline. So you need to remember that the more you go to the first generation, you get more gram-positive. The more you go to the fifth generation, you get more gram-negative coverage. So example, on first generation, it covers gram-positive cocci, but does not cover MRSA. So it's only Staph MRSA. And therefore, it's a very good for skin and soft tissue, such as abscess, erysipelas, furuncles, folliculitis. And the second generation has more anaerobe, in addition to have more gram-negative than the first generation. An example, we can use it for abdominal surgery, for pelvic inflammatory disorder, and for community-acquired pneumonia. The third generation has more gram-negative, and it's become equally effective, the third gen. That's why they are commonly used. They are equally effective in gram-negative and gram-positive. But again, they cannot treat MRSA. And the ceftazidime covers Pseudomonas. So you need to remember that. The more you go down, the longer the action. So you can give, less, or you stretch out the space, stretch out the doses, the duration between the doses. You can stretch apart the doses. And that's why they are very good for meningitis, UTI, pneumonia, and they also work for Pseudomonas. The fourth generation, they're very, very good against Pseudomonas. and therefore, and they have gram-positive and gram-negative. The fifth generation, the difference is they cover, sorry about that, they cover the difference, the fourth generation, the ceftaroline, it works against Pseudomonas, it covers gram-negative and gram-positive, but it covers MRSA. And therefore, it's very good against MRSA if you are suspecting Staph aureus resistance. Cephalosporin, cross-reactivity. So the cross-reactivity with penicillin, the more you go to the lower generation, the more cross-reactivity with penicillin. So it's very common with cefazolin and cephalexin, but it's less common once you go down in the generation, or sorry, up in the generation. Despite they can cross-react with penicillin, so if you have allergy to the penicillin, they might have, but they are very rare. So very rarely you find allergy to cephalosporin, but once you have allergy to penicillin, they usually have common allergy to cephalexin. Well, again, the cephalosporin allergy in general population are rare, but in patient with penicillin allergy, they are common. The other antibiotics is the meropenem, and the other example are the atropinum and imipenem. The imipenem sometimes combined with cilastatin, and we call it primaxine. What they are good for? They are good for gram-negative bacteria. They cover bacteroid flagellus, they cover Enterobacteriaceae, and they cover also Pseudomonas. They cover gram-positive bacteria. They are good against Listeria, and they are good against Enterococcus faecalis. They are very good antibiotics. The problem is overusing them and easily switching to them. And therefore, we are facing resistance. And you know, if you have resistance to meropenem, you develop what we call it superbug. And the superbug, you have no defense against. They will kill the patient. And the most important point here is resistance. So you do not need to use meropenem. I rarely ever use it, maybe once a year. They're very good for intra-abdominal infections, such as peritonitis, abscess, and when you have severe unresponsive neck, necrotizing enterocolitis. The Asthrionum, or the Asthronium, sorry, I'm misspelling it. The Asthrionum is very good when you have allergy to penicillin. And the problem of the Asthrionum is we cannot use it with Aminoglycoside. It goes very good. This is misspelling. It's a penicillin. There is no G. So it's very good for against gram-negative bacteria, and it also covers the Pseudomonas aeruginosa and Enterobacteriaceae. But remember, the Asthrionum is not good for gram-positive bacteria and is not good for the anaerobes, and therefore is not good, for example, for soft tissue infection, and is not good, for example, for bite or for aspiration. What about clindamycin? It inhibits cell wall synthesis, one. Second, by binding to the 50 subunit, as we discussed in the ribosome, and it's very good against anaerobes, against MRSA, staph and strep. Therefore, it's very good for soft tissue infection. However, there is a very stigma for clindamycin, which is development of the diarrhea caused by Clostridium difficile or toxic megacolon. The aminoglycoside, very important medication. An example is gentamicin, tobramycin, amikacin, and streptomycin. They inhibit bacterial protein synthesis by binding to the 30 subunit of the ribosome. They are very good for gram-negative, such as E. coli, Yersinia, Francisella tolerances. Also, they have some activity with staph, Mycobacterium, Entamoeba histolytica, and Cryptosporidium pavum. They are very synergistic with ampicillin. And because this ampicillin is a broad spectrum and good for initial therapy, and because ampicillin also covers Listeria monocytogenes, they are very good start for ampicillin gentamicin. There is no need to start meropenem in unit. The problem with aminoglycoside is nephrotoxicity and ototoxicity. So they're very good. The ampicillin or gentamicin is very good for in-hospital infection, while the amikacin is very good for outpatient infection. The reason, because many people use gentamicin for diarrhea that is most commonly caused by virus, and that's why we have resistance. So if you have a baby born indoor or came from labor room, then the best is ampicillin gentamicin. But if you have baby at 7 days admitted from outside, then the best combination is using amikacin, not the gentamicin. The tobramycin are very good for local, such as conjunctivitis, and streptomycin, we can use it for mycobacterium. The most common indication for aminoglycoside is neonatal sepsis, also bacterial endocarditis, tuberculosis, and complicated intra-abdominal infection. You don't need to add meropenem. Gentamicin is very good start antibiotics. Also complicated urinary tract infection, and nosocomial respiratory tract infection, and also for the plague. Now, the problem is the toxicity, and therefore you need to check the level. So we check two levels, the trough and the peak. Although I don't care about the peak, I only measure the trough. The peak is the after the dose. The trough is before the dose. So most commonly, we test it after the second dose, before the third dose. We measure the trough level. Sometimes we do it on day 5. And the reason, because most commonly, we need 2 doses. We don't need the third dose, because 99% of the use of aminoglycoside, it turned to be not infection. And only 1% is actual infection. We need to continue. And therefore, we need to check the trough just prior the third dose, or we can check the dose or the peak after the dose. So the trough level is somewhere between 0.5 to 2 mic per mil, and it becomes toxic when it is more than 2. So if the trough is high, you just need to stretch out the dose. So if you are giving it every 12 hours, you make it every 18 hours. If you are giving it every 18 hours, you make it every 36 hours, every 48 hours. If the peak is high, you drop the dose by 25%. So most of stretching out the dose will correct the trough. Rarely you need to stretch out the dose or increase or apart the duration. Again, you don't see, again, do you guys see the presentation?
Yes, we can.
Yes. Dr.
Yes,
Yahya,
I can see.
I have
You
a
cannot
question.
You cannot see, or you can see?
We can see.
We can see.
You can see. Okay, give me the question.
Excuse me, Dr. Yahya, I have a question.
Yeah, give me the question.
About the use of aminoglycosides in neonates. Is it better to give it as a single dose or divided dose?
What do you mean single dose or divided dose? I didn't
BED
understand
dose
the
or
question.
OD dose?
What's the meaning single dose or divided dose? What do you mean by that?
I mean, you calculate the dose And that dose, you either give it all as a single dose or you divide it by every 12 hours.
You don't need to divide it. You don't need to divide it. Just give it, calculate the dose according to the gestation, according to the postnatal age, according to the weight, and according to your renal function. You calculate the dose, and then it will tell you also the dose and the duration. So it might tell you 2.5 per kg per dose every 36 hours, every 24 hours, every 12 hours, every 18 hours, or it might tell you 5 milligram per kg per dose or per 24 hours. And it tells you all the details, the dosing system, it's all available. Despite all this, being careful, selecting the dose based on the weight, the postnatal age, the gestational age, and the renal function, you still might having toxic effect, and therefore it's vital to check the trough. I don't check the peak, I only check the trough.
Okay, since
and
the doctor,
then you give it over 20 to 30 minutes, and you give it by dilution, and you don't give it like you have to dilute it and give it over 20 by infusion pump, over 20 to 30 minutes. Yeah, go ahead, please.
And another question, since aminoglycosides are nephrotoxic, is checking renal system renal function is daily is obligatory?
Well, it's very complicated question, because the renal function, you need to check it in most babies admitted to an ICU, especially those sick enough to need aminoglycoside. So first, you have to check the renal function and electrolyte every 24 hours in most babies. And some of the sick babies, such as 25, 24, 23, 27, you need to check it more than once. If there is, first week, they all usually exposed to hypernatremia, hyperkalemia, hypercalcemia, hyperglycemia. So you need to check it frequently. But let's say the baby is completely fine, term baby, and you are planning to give it 48 hours, and you have a culture waiting the culture, there is no need to check the renal function. Just because you are, but if you are extending more than the third dose, you're giving more, you need to check renal function, and you need the level.
Okay, thank you very much.
Thank you. In case you cannot check the level, well, if you cannot check the level, then you need to be careful. So it's better not to use it. That's one. Second, if you want to use it only for 2 doses, and do the blood culture. And if you don't have blood culture, there is no other option other asking blood culture. Antibiotics without blood culture is you are just harming the babies. You won't have a good result. So blood culture is vital. So if you don't have level, that should be okay, but you have to be very careful. Check the weight, check the gestation, check the postnatal age, check the renal function, and give the lowest possible dose. Only give 2 doses, unless you are having, and please and kindly, avoid CRP, avoid ESR, avoid procalcitonin. They are garbage. They are unnecessary. They don't give you any benefit. Don't read these numbers. They actually sometimes go down. Sometimes they go up. Maybe you are resolving, but they go up. They depend on many factors. Don't give antibiotics because of inflammatory. The antibiotics only based on culture. Okay. So what about the macrolides? An example is the azithromycin, clarithromycin, and erythromycin. They work as a bacteriostatic by inhibiting the 50 subunit of ribosome. And therefore, remember, they increase motility of the bowels.
Excuse me, the slide is at aminoglycosides. It's
not moving?
Not moving.
No?
Not
No,
moving.
not moving.
Not moving.
Okay. Now?
Yes, yes.
Now it's
Great.
macrolides.
Yeah, so the macrolides example is the azithromycin, clarithromycin, and erythromycin. They inhibit the 50 subunit of the ribosome, and they are motilin agonists. So they increase the movement of the bowels, and therefore they may cause hypertrophy of the bowel wall, and they are associated with pyloric hypertrophy. So you need to be very careful when you use it in neonate. They are good for gram-positive bacteria, but they have no good coverage of gram-negative. They are very good against H. pylori and pertussis. They are very good against mycoplasma and chlamydia. They cause very important GIT upset. And as I say, because they increase bowel movement, they are associated with hypertrophic pyloric stenosis in less than 1 month. We use them most commonly in neonate for prophylaxis of conjunctivitis. But remember, they do not cover chlamydia. So in last 1 year, we stopped using the erythromycin as prophylaxis eye drop. We've discovered it's unnecessary. So there is no need to give eye cover prophylaxis. If you see eye infection, if you see congestion, if you see discharge, you need to send swab for culture and give 1 dose of ceftriaxone, waiting the result. Using erythromycin is not important because 50% they don't cover chlamydia. And if it's other bacteria, it's not very dangerous. And if it's a gonorrhea, erythromycin will not work on it. So you need a ceftriaxone dose. And therefore, giving erythromycin, eye drop or ointment prophylaxis is not necessary and is not recommended. The best practice is when you see swelling eyelid, congested eye, redness, or discharge to give. And if you suspect, especially gonorrhea, and if you suspect gonorrhea, you need IV, you need a blood culture, you need lumbar puncture, you need a urine culture, you need hospital admission, and you need at least 21 days of IV antibiotics, even if it's local, because very dangerous bacteria. But also, what you can do, it can work on chlamydia. You can give 1 dose of ceftriaxone pending the cultures. Rifampicin, it works very good against tuberculosis and invasive Haemophilus influenzae, influenza type B. It inhibits DNA-dependent RNA polymerase, and it's very commonly used in the close contact of meningococcal infection. And it's combined with vancomycin in certain staphylococcal infections, such as in VP shunt, osteomyelitis, and endocarditis. And it's also important use for persistent group A streptococcal pharyngitis when we combine it with beta-lactam, such as amoxicillin or augmentin. It's very good treatment for MRSA carriers, and it causes red, orange body fluid, and also cause hepatotoxicity. Do you guys see the slide of rifampicin?
Yes.
Okay, great.
Yes.
Now we go to the fluoroquinolones. Example is ciprofloxacin, ofloxacin, levofloxacin, and gatifloxacin. It inhibits DNA-dependent RNA polymerase, exactly like the rifampicin, and it's used only when there is multi-drug resistance bacteria. It's only used when the other drugs are not safe. And it's only used when other IV antibiotics is not available. It's used also for MRSA carriage. And you use it for complicated multi-drug resistance gram-negative roads And we use it for Pseudomonas aeruginosa, especially when the infection of the nail of the foot. We use it for chronic or acute osteomyelitis. You give steroid. Why, sir, you give steroid? Well, you don't have blood culture and you give steroid. Why you give steroid? Sir, giving steroid to sepsis or ill patient is incorrect practice.
Maybe
When
he
you have
meant
sick patient-
antibiotics. Maybe he meant antibiotics.
Sorry?
Maybe he meant antibiotics. Just that was misunderstanding.
Yeah, okay,
Steroids.
maybe. But again, I want to insist on this point, is that giving steroid to sick patient is incorrect practice. You give steroid when you do supportive care. So when you have patient is sick, you support the breathing. Maybe the baby need intubation and ventilation. You support the cardiovascular system, heart, central or peripheral vascular resistance support. You need to support the kidney. You need to support the bowel. You need to support the brain by giving sedation. And if all that happen and every you think and still the baby is sick and you have hypotension that is not responding to conventional medication, now you need steroid. And remember, when the baby gets sick, he is or she is not pin, you throw everything in. And when the baby gets sick, it does not mean you need to change the antibiotics. That means that the baby needs support. When baby gets sick, the baby needs support, not changing antibiotics. Changing antibiotics will not save a baby. When baby gets sick, needs breathing support, breathing support, breathing support, breathing support, breathing support, breathing support, and then cardiovascular, and then brain, sedation, and then kidney and bowels, and now you consider antibiotics. When baby gets sick, they need support, not antibiotics, and definitely not steroid. So whatever the question, what about steroid? Tetracycline and doxycycline, they inhibit the 30, Dr. Salma, please mute yourself. So they inhibit the 30 subunit of ribosome and they inhibit the cell wall growth or a protein, sorry. And they're very good for tick-borne infection. And they are very good for Properiobacterium causing the acne. And they are very good for MRSA. They are not encouraged to be used below 8 years of life unless life-saving infection such as the roty-mountain spotted fever that is developed some states of United States, and they cause dental staining, and dental staining are permanent. They will never clear out. What about the trimethoprim that is usually antibiotics is overlooked and very good antibiotics. It's very good for UTI. It inhibits folate synthesis, by the way, and it affects the DNA and protein synthesis. And therefore, you might need to supply with folate when you use it over a longer period of time. Now, it's very good for UTI, methicillin-resistant staph, and pneumocystic gyrovece. It's very good for Shigella and Salmonella gastroenteritis when the culture is positive. Only culture is positive, remember. We use it for Burkholderia cepacia that is usually common with cystic fibrosis, and it's very good for Brucella. Vancomycin, very good drug. It inhibits cell wall synthesis. It causes autotoxicity and nephrotoxicity. So when you use it with aminoglycoside, please be careful. They should develop resistance. Very difficult to develop resistance, but remember the misuse of it. And we develop the shock from it, or what we call it, the red man syndrome. We need to monitor the level. We need to give it slow infusion, and if you develop side effect, it's a very good antidote is diphenhydramine. So when we only need to check the level, when we check the level, we check the trough, we don't need to check the peak because the toxicity caused by steady level, not by the spiking of the level. And usually I check it just prior the 5th dose. Normally is level is 15 to 20. When the level is 15 to 20, the minimal inhibitory concentration will be more than 1 mic per mil. When the level is 10 to 15 mic per mil, the minimum inhibitory concentration that can kill bacteria is less than 1 mic per mil. We use it in neonate for highly suspecting MRSA, such as those associated, or we call it CLABSI or catheter-associated infection, central lines, or if you confirm MRSA. Because the minimal inhibitory concentration in neonate, we need it level, so we usually target a level of 10, about 10, 11, 12 mic per mil. If you have coagulase negative staphylococci or enterococci, a level of 5 to 10 mic per mil may be enough. So if the dose is high, or if you have renal problem, you can prolong the dose. So you switch it, you stretch it out, or you make it apart, or you can decrease 20% of the dose. If the dose is low, you can increase the dose by 10% or 20%, depending on the situation. So how we chose antibiotics? For neonatal sepsis, it's ampicillin and gentamicin. It's not vancomycin. It's not cefotaxime. You don't need 3 antibiotics. Using antibiotics will not save babies. Babies, when they get sick, they need support. They need proper ventilation. They need proper ventilatory support. They need proper cardiovascular support. They need a good sedation. They need pain control. They need cardiovascular support. They need proper use of inotropes and chronotropes. They need a proper control of the bowels. They need good nutrition. Antibiotics, using triple antibiotics. Dr. Lumnia, if you can mute yourself. So I lost my concentration when I was talking.
Babies need support.
Yeah, so
Support.
remember, nutrition is very, thank you. Nutrition is very important part of helping the babies that we forget. So we put the baby on dextrose, but we give antibiotics. So how the baby will fight the disease if you don't give him protein or fat or multivitamins? How come? So you give antibiotics, baby on D5, no feeding, no TBN, and you want the baby to survive. If you have gonococcal conjunctivitis in newborns,
Sometimes they survive.
Sometimes they survive by, yeah, they are good fighters. Sometimes they survive, yes. Yeah. But if they survive, it's not because of antibiotics.
Yes, I agree.
They only survive antibiotics when the culture is negative, when the culture is positive. So if you have gonococcal conjunctivitis, remember, it's a serious infection. You need hospital admission. You need IV ceftriaxone. Erythromycin will not help. You need lumbar puncture. You need blood culture. You need renal, you need bowel ultrasound. You need urine culture. You need head ultrasound. You need echo. You need to make sure that there is no other focus. And you need probably 21 days of antibiotics. So remember that. They need support. When you have chlamydia conjunctivitis, you can treat the chlamydia conjunctivitis by erythromycin, even topical. When you have meningitis, sepsis, first time, less than 30 days, ampicillin and gentamicin is enough. When you have meningitis, sepsis, second time, and you have Lyme, you need vancomycin with the gentamicin. When you have meningitis, bacteremia, 30 to 60 days, consider ceftriaxone. for two reasons, because you might have more gram-negative than gram-positive. You have less GPS. When you have meningitis, bacteremia, more than 60 days, vancomycin, either ceftriaxone or cefotaxime, don't use the ceftriaxone in a neonate, especially with jaundice. When you have streptococcal pharyngitis, oral penicillin is very good. You can go penicillin if you if a remote area you want to give one dose. If you have dental infection, it's oral penicillin. If you have acute otitis media, you need both gram-negative and gram-positive, and you need antibiotics that invade the soft tissue. So amoxicillin, augmentin, ceftiofur, and ceftriaxone are very good choices. So the most important, if we start some antibiotics and waiting for a blood, some antibiotics, you start some antibiotics, or you need to start antibiotics. Okay. Why, sir? Why, Dr. Fatma? Why you don't open the mic and ask me question? Why you take long time to type and then I have to read? So why don't open the mic and ask me the question? What do you think?
Assalamu alaikum.
Alaikum salam.
Okay. I talk about in case of meningitis, as written in the slide, there is ceftriaxone and amoxicillin, and ceftriaxone and vancomycin. Need to be used in both antibiotic, or even one is enough?
I did not understand the question. So you have meningitis, and which gestation, which age?
Yeah, like an example, beyond 60 days.
So you have meningitis confirmed, and the baby is more than 60 days.
Yes.
Okay, what's the question?
My question regarding antibiotics, as written in the slide. You they wrote that ambi and ceftriaxone.
So ceftriaxone, cefotaxime, with or without vancomycin? It depends on the situation.
Okay.
So if, so it depends on the situation, depend on risk factors, depending on other, okay?
Yeah.
So
Okay.
it depends, because you have more gram-negative, you have more Haemophilus influenza here. So
yes, exactly.
staph is a good possibility. And remember, staph is a destructive bacteria because it has coagulase, so it eats the tissue. So it's very important to consider. Now, if it's in the hospital, it's different from the patients outside the hospital.
Yeah.
So it depends on really on the situation. What is exactly the situation? Is it a immunocompromised? Is it has a previous infection or not? What was the gestation? Whether the baby was admitted or not? What was the complication? It depends. But mostly in this very important gestation with meningitis, you might need to consider triple antibiotics. So somebody is raising hand. Who's that?
Okay, thank you.
Thank you.
Doctor,
who want to ask question? Please go ahead.
Yes, doctor. In some guidelines, I read that in patients with neonatal sepsis who are also having neonatal jaundice, that giving ceftriaxone is contraindicated. So how do we manage those patients? Because they said
so neonatal sepsis, and you have only ceftriaxone. You want to give ceftriaxone, and the baby has jaundice.
Yes, doctor.
Yeah, so you need to just be careful. So it will increase the jaundice. So if you don't have choice, you have to use it. So jaundice or death, jaundice. So if you have only ceftriaxone, and there is, you can use it in neonate, it's not contraindicated. But if you have jaundice, just check the liver function and then adjust the dose accordingly. But if you have other choice, you can use it. You can use other doses. It's not a must to be ceftriaxone. Neonatal sepsis, the second point, you don't need cefotaxime or ceftriaxone. Ampicillin and gentamicin is more than enough. But if you don't have other antibiotics and you have only ceftriaxone and the baby is jaundice, so you are very in unlucky situation, then you can use it and check the liver function. And if there is liver function deterioration, then just adjust the dose. And considering that your blood culture is positive. So also consider to stop antibiotics as early as possible. Any other question? Okay. So how we use antibiotics? What is the proper? Yes, Dr. Shakir.
Assalamu alaikum.
Alaikum salam.
My question was, if we have started some second generation antibiotics, cephalosporins, we have sent
You
for blood
started
culture.
cephalosporin.
Second generation, okay.
Second generation cephalosporin, okay.
And we have sent for blood culture.
Okay.
And we are waiting for the culture. It will take some 3 to 4 days.
So here, one comment. You don't need the result. So you need only, wait, let me answer you.
Okay.
You only, either you need the result report or there is no report. So if there is no report at 48 hours, consider it negative. You don't need to wait the report. So again, either 48 hours, either there is no report or the report is negative, because there is something called yield of the blood culture. If you go and read about blood culture, the blood culture positivity depends on many factors: the volume, how many sites, and the yield. So the yield of blood culture 12 hours is 40%. So if the blood culture negative at 12 hours, there is 60% chance that there is infection. At 24 hours, the yield is 70%. So if the culture is negative at 24 hours, there is 30% chance that there is infection. The yield at 36 hours is 85%. So if the culture negative at 36 hours, means there is 15% chance that you have infection. The yield at 48 hours is 95%. So if the blood culture at 48 hours not reported, they don't send you the report, because if it's positive, very obvious, they will also send you and say, oh, doctor, there is gram negative. So if the blood culture, there is no report, at 48 hours, the possibility you have infection is 5%. At 72 hours, the yield is 99%. So if the culture is negative at 72 hours, or there is no report, mean only one chance you have infection. Now, if you wait 48 hours and you are asymptomatic, so you are asymptomatic, your CBC is benign, and you are asymptomatic, or your symptom improved, then you have at 48 hours, they yield only 5% chance of infection. But with CBC, such as no leukocytosis, no increase in IT ratio, no leukopenia, and also you have no thrombocytopenia, and you have no symptoms, then adding these three make the yield 99.9%, there is no infection. Okay? Now, if there is infection, and the baby is symptomatic, because people say PP is symptomatic, if the baby is continuous symptomatic, that means it's not due to infection, or the antibiotics you are using is not working. So what you should do, you should switch, do another culture. You cannot change the dose or the duration or the type of antibiotics without another culture. So this is a big problem here, because blood culture negative and say, well, it can be culture negative sepsis. Now the culture negative sepsis in neonate is only 10%. So if you have 20 babies in your NICU, and 10% of them on antibiotics, or like you have 10 babies on antibiotics, and you did culture for all of them, okay?
Okay.
And you have, you're using, let's say 10, so 50% of your NICU is on antibiotics, okay? And you did 10 cultures, okay? And 9 of them is negative, and only 1 is positive. Now you are overusing antibiotics, because you have 40% culture negative sepsis. And normally the culture negative sepsis or the clinical sepsis, and they mean that either the volume or the site was negative and did not catch the bacteria that is in the blood. So if that's the situation, mean you are overusing antibiotics, and the reason for your baby's symptom is other than infection. So, but if you have 20 babies and only 2 of them on antibiotics, and 1 of them is positive, and 1 of them is on antibiotics, so 2 antibiotics out of 20, and 1 of them is culture positive, then probably you're correct. So you need to be careful. The reason is antibiotics cause resistance. Not only that, but you change the biome of your unit. So it does not affect only one baby, it affects other babies. Because remember, the nurses and the staff and the respiratory service carrying the baby will transfer the infection, so it will change the biome of your unit. So with time, you will have a cluster of complication or cluster of neck, so it's vital to avoid antibiotics to have a good unit or good. So please don't type of all of it. Don't type. If you want to ask me question, ask me, because I cannot read. So let me finish neonatal sepsis and I will answer. Did I answer your question, Dr. Shakir?
Yes, thank you. Jazakallah.
Okay, so how we start antibiotics for neonatal sepsis? First, we consider the risk. Second, we should have signs and symptoms. We should not start antibiotics just because symptoms and signs. We should not start antibiotics because we have risk. We should have both to do sepsis workup. So what are the risks of infection? Baby in labor. If the mother is contracting, if the mother is in labor pain, this is a risk of infection. If we have rupture of membrane more than 18 hours, but it's more for 4 hours if you're talking about herpes. If the mother is febrile, if there is leukocytosis, if there is tenderness of the uterus, if they are GPS positive, if there is urine or vaginal swab positive, if you have previous neonatal sepsis, if you have previous unknown cause of neonatal death, if you have fetal distress, if you have fetal growth restriction, all these are risk of infection. But these does not mean that you should start antibiotics. You should have symptoms. Symptoms are any baby who is not responding the first 2 steps of resuscitations. The first step, we use it for any baby, which is dryness, warming, position, suction. That's the first step. The second step, stimulation. So any baby who need resuscitation at delivery more than stimulation, such as providing PPV or providing oxygen, this is considered symptom. If you have any of these risk factors and any of these, then the baby ward sepsis workup. Remember, it's always correct to start antibiotics. And you must start antibiotics. But it's always incorrect to continue antibiotics more than 48 hours and some unit 36 hours, even if you don't have report of blood culture. When to start? You have risk and you have sign or symptom. Also remember that being premature, less than 37 weeks, is considered symptom. If you have respiratory distress, if you have poor activity, if you have hypotonia, if you have abdominal distension, hypoglycemia, vomiting, temperature instability, whether hyper or hypothermia, tachycardia, bradycardia, apnea, seizure, feeding intolerance, these are all considered symptoms. So either if you have any of these or plus any of these, you need sepsis workup. And when we say sepsis workup, we mean CBC, culture, ampicillin, gentamicin, 48 hours, either negative or no report. And the baby should be asymptomatic. If this happens, then you need to stop antibiotics. So again, it's always correct to start antibiotics. It's always incorrect to continue antibiotics if the culture is negative. And please do not send CRP. Do not send ESR. Do not send procalcitonin. They are useless. There is no benefit of using them. They are only prolonging antibiotics use. You're only increasing the chance of getting NEC in your unit. You're only changing the bioma of your babies. They are not beneficial. I never use ESR or CRP in my life. And I rarely ever having death. Okay, so what is then if I have risk and or symptoms, what I should do? Goodness, you're coming and going, coming and going, coming and going, giving me busy of coming and going. So what we should do then? We do monitoring. So if we have risk or symptoms, but not both of them, there is no need to start antibiotics. So for example, mother comes not in labor, she's hypertensive. They induce the labor and you get a premature baby. You don't need to start antibiotics. Mother not in labor. They did C-section because the mother is diabetic and baby get respiratory distress. There is no need to start antibiotics. We need to monitor the baby. So risk or symptoms or sign, you need monitoring. So what you do CBC, you check the vital sign every 6 hours, you keep the baby 48 hours, and you keep the baby with the mother if no other factor indicating admission. So how we do, what we do when we do sepsis workup? So we do the sepsis workup, and if the culture is positive, we repeat the culture in 48 hours. We give the antibiotics between 7 to 14 days. With the other condition, the culture should be negative. So if we start antibiotics, we do blood culture within 48 hours. If it's still positive, we repeat in 48 hours. If it's still positive, we repeat in 48 hours. So we give the antibiotics, depending on the type, between 7 to 14 days, with a must that we have 2 days culture negative. But if you have meningitis, you might need to continue to 21 days. Again, with 2 days culture negative of the blood culture and the CSF. And then you send the baby home. Now, if the culture negative, you have to make sure you have not having culture negative sepsis. And this not depend on the baby, depend on whole unit. So if you have suspecting culture negative sepsis, you need to give the antibiotics about 5 days. And again, repeat the culture within 48 hours. If the culture 48 hours negative, the second culture, and 5 days is passed, then you send baby home. What about if we do monitoring? So we do CBC, vital sign every 6 hours, 48 hours of hospital monitoring with the mother, no sign and symptom, then home. If there is sign and symptom develop, then you do sepsis work. Is it clear, neonatal sepsis, how we treat?
Excuse me?
Yes, go ahead.
What we mean by with 2 days culture negative? You mean that after 2 days of antibiotic or second?
So let's say
or two cultures negative.
So let's give you example so you understand.
Okay.
You have a 2 days old baby, 26 weeks old baby, and you did sepsis workup.
Okay.
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 And the sepsis and the blood culture that you did came positive.
Okay.
and it came to be group B Streptococcus. And you decided that you will go for 7 days antibiotics.
Okay.
After you did the first culture, you have to repeat the culture after 48 hours.
Yes.
The second 48 hours was positive too. So you repeat the blood culture on day 6.
Yes.
Now, if the culture is positive again, and you decided from the beginning 7 days, you have to extend it to 8 days.
Okay.
You got me? So if the culture is positive, after 48 hours, which is on day 8, you repeat the culture and you continue antibiotics until day 10. So you already give 7 days, but also you added 2 days of culture negative. Mean 2 days after the last culture negative.
Yes.
Some of the dangerous bacteria, you might need 2 culture negatives. So let's say you have a gram negative and you decide to go for 21 days. I usually like 2 culture negative. So I need 2 days, 21 days of antibiotics and 2 culture negative. So I do culture negative on 1 and then 48 hours and then 4 days and then 6 days and then continue until it's negative. So in gram negative, I usually like 2 culture negative, 2 days apart. So if the day 18 was negative, then 21 days. But if day 20 is positive, 21 days is not enough. So I have to go 22 and repeat the culture. So mean that you go for the duration you decide and 2 days after the last culture negative. Is that clear?
Yes.
Okay, so
Dr.
again,
Yahya,
yes, sir.
In a situation where there is no, we can't, or there is no checking of gentamicin level, is it better to combine ampicillin with cefotaxime?
No, it's not better. Gentamicin is way important, way more important than cefotaxime. Cefotaxime is a weak medication. Cefotaxime is a broad spectrum. Ampicillin is, gentamicin is very limited spectrum. And gentamicin is synergistic with ampicillin. So no, and cefotaxime is important antibiotics for more serious infection. Gentamicin is important than cefotaxime. And most of time, within 3 days or 3 doses, if you're giving it every 24 hours, you will not develop renal problem. If you want to extend more than that, then you need to do renal function. And if you think the renal function are deteriorating, so if you do on day 3 renal function and you get poor renal function. Now, if it's due to antibiotics such as aminoglycoside, do it next day. And if it's keep deterioration, it might be due to the aminoglycoside. So you have many options: decrease the dose, switching apart or stretching apart the dose, but not switching to cefotaxime. Cefotaxime only indicated when the baby comes from outside, but it's better to use amikacin than cefotaxime. Cefotaxime is only indicated when the culture comes tells you that the aminoglycoside is resistance and cefotaxime is sensitive, or if you did CSF and it's meningitis. So probably you might think of cefotaxime, but there is no need to switch to cefotaxime just because you're fearing that you don't have level. These are just excuses to think that antibiotics will save the baby. When baby deteriorate, they need support. They don't need antibiotics. Is that clear, sir?
Okay, thank you. Thank you so much.
Assalamu alaikum.
Alaikum assalam.
Yahya, about if blood culture negative, why I will repeat again for 48 hours? And if
no, you don't need to repeat. We didn't say that. You don't need to repeat. Only if it's culture negative. So if you do culture and it's 48 hours, you stop antibiotics. Why you should repeat? But if culture positive and the repeat, then you go for the duration of antibiotics and you keep repeating the blood culture every 48 hours until you have culture negative. So you have to go for 7 days antibiotics with last 2 days culture negative. Yes, mom, tell me.
In the diagram, in sepsis workup, if blood culture negative sepsis, 5 days antibiotic, repeated culture after 48 hours. Yeah,
Because it's symptom and you're continuing antibiotics.
Still symptom.
So it's a culture negative. What is the meaning of culture negative sepsis? There is sepsis, there is bacteria, but you think the culture did not pick it up, either because the volume was not good or the site that you took the picture was not there. So you're thinking there is infection, but your blood culture, because of the volume or because of the site, didn't pick it up, or because your incubation is not correct, or you're not trusting the lab. So you think there is sepsis. As far as you think there is sepsis, you need to repeat.
Okay, if the patient after starting antibiotic and still symptomatic, and I will repeat the blood culture at this time.
No, I did not say that. I did not say that. I have to be careful. I did not say the baby is still symptomatic. No, mom. You think baby symptomatic maybe for other reason. Again, you think that there is infection, but the culture did not pick it up. Whether the baby is symptomatic or not symptomatic, this is a different issues. You think that there is infection, but I cannot say give antibiotics because the baby is symptomatic. Baby is symptomatic for other reasons. I don't give antibiotics because the baby is symptomatic. If culture is negative, I stop antibiotics. Now, if I stop antibiotics and the baby has symptom, maybe from other reasons, PDA, RDS, TTN, hypoglycemia, I don't know what's the symptoms, heart failure, congenital heart disease, a metabolic, I don't know what's the hypothermia, I don't know what's the cause, poor support, no sedation, symptoms for the baby has symptomatic. If the culture is negative, I stop antibiotics, baby symptom or not symptom. Now, what if you tell me, what doctor, if you stop antibiotics and your culture negative, but it might be wrong? Yeah, when you stop antibiotics and you think that the antibiotics will save everything, the baby will deteriorate. So once the baby deteriorates, do another culture, resume antibiotics.
Yes.
There is no reason to continue antibiotics other than feeling you safe. That's all. It won't add anything.
Yes.
So if you think the baby has symptom and you think these symptoms are from infection, and you think that your blood culture is not picking up, which is very unlikely, because if the bacteria in the blood and causing symptom, it should be very high. It should be easily to be picked up. But let's say a baby is symptom due to infection, and you did blood culture, and you were very unlucky to find no one, and you want to continue antibiotics. This is wrong. You have to stop antibiotics. You have to find other reason why the baby is deteriorating. You have to look for your support, your ventilation, your invasive or non-invasive support, your nutrition, your cardiovascular support, your GI support, your sedation, other causes, comorbidities. If all that is okay, and you're very sure that you're doing perfect job, and baby deteriorate, because remember we said it's always correct to start antibiotics, but it's always incorrect to continue. Do another blood culture and resume or add a new antibiotics. I don't care. But just changing antibiotics, continuing antibiotics, make no sense to me. Is that clear?
Yes.
Excuse me.
Okay. So,
Excuse me.
yes, go ahead.
So if the baby is preterm, 30 weeks, it's okay to start antibiotics and after 48 hours to stop, or better not to start?
Okay, so if the baby is 30 weeks, depending, so this is symptom. We agree that prematurity is a symptom or sign. So if symptom, if somebody tells you, and it's sign if you see it. So we agree that this is a symptom. Is there a risk factor? So for example, is the mother was in labor?
No, that maybe placenta previa or something like that. Babies.
So if a mother is not at risk, if another risk, rupture membrane, fever, tender uterus, any other risk factors, previous death, previous GPS, any baby's fetal growth restriction, small weight, any other risk factor of infection, leukocytosis for the mother, mother vaginal swab is GPS positive, or culture vaginal swab, or blood culture positive of the mother, or urine culture, any risk factors in the mother, or mother is in labor, plus any sign, this works sepsis. But if you have only sign, but no risk factors, there is no need. For example, if mom came perfectly, nothing, normal pregnancy, but they deliver her out because she was bleeding due to placental problem, and baby born premature, then no need to do sepsis workup. However, you need to monitor the baby. If the baby deteriorates, so if you have prematurity and hypoglycemia, plus you have, for example, metabolic acidosis that you cannot explain, then you need to do sepsis workup. But remember, when you monitor, once you feel that you should start antibiotics, do blood culture, wait 48 hours. So when we say premature and mother is not in labor, when we didn't do sepsis workup, we're not sending the baby home. We're monitoring the baby. If the baby deteriorates, then do sepsis workup. But
baby's on CPAP. Baby's on CPAP.
Baby on CPAP because of respiratory distress.
Yes.
And because he's premature.
Yes.
No need for antibiotics. Because there is no risk. There is a risk factor.
I think placenta previa was that.
But no, any other risk factor of infection.
No, but baby then deteriorates after 3 days.
Baby deteriorate, then do sepsis workup, start antibiotics.
Okay, thank you.
But baby deteriorate because of RDS or no RDS?
Because of sepsis.
Yeah, probably sepsis. I don't know if it's sepsis, no. But anyhow, if the baby deteriorates, it's correct to do sepsis workup. Then that's not a problem. But I mean, when we give the risk factors and the symptom, we mean at birth. But if remember, if we go to the monitoring and the baby develops sign and symptom, you do sepsis workup.
Thank you.
So, you're welcome. Acute mastoiditis. So we need staph and we need soft tissue. So ceftriaxone and cefepime is a good choice. Preseptal cellulitis. When you say preseptal, we mean that's mostly staph. So it's a good choice to go use cephalexin, clindamycin, or methoprim. Remember, clindamycin also, if you give it oral, it might cause esophageal ulcer. Trimethoprim is a good choice, but remember, it's the side effect. If it's preseptal cellulitis following sinusitis, mostly streptococcus or night-on typable Haemophilus influenzae or Marxella cataralis, then augmentin is a good choice, cefdinir or ceftriaxone. Pneumonia due to streptococcus pneumonia, ampicillin, amoxicillin is the choice. Pneumonia at school age because of my risk of mycoplasma, azithromycin, erythromycin is a good choice. Osteomyelitis due to staph. If it's MESA, then it's a Nafcicillin, cefazolin. If it's MRSA, then vancomycin, linezolid. We might add third generation cephalosporin for possibility of a gram-negative and better penetration if we are less than 3 years. Osteomyelitis, Pseudomonas is the main problem, especially if there is a device, then ceftazidime or ciprofloxacin if we are more than 12 years. Osteomyelitis due to salmonella, or you have sickle cell anemia, then cefotaxime and ceftriaxone is the choice. Osteomyelitis in immunocompromised caused by Kingi, then ceftazidime IV or ciprofloxacin. Syphilis, we give penicillin. What about UTI? Methoprim, cephalexin, augmentin, cefixime, cefazolin, cefotaxime, ceftriaxone, or ciprofloxacin. If we have tissue cellulitis and MESA, then cephalexin, cefazolin, or nafcicillin, depending on IV or oral. If it's MRSA, then methoprim, clindamycin, vancomycin, or linezolid. Post-operative prophylaxis, cephalexin, cefazolin, cefixetine, imipinam with cilastatin or the primaxine or peptazole. Pseudomonas infection, ciprofloxacin, Asthrionum, ceftazidime, cefepime, or peptazole. Dog bite, augmentin or ampicillin with sulbactam. Dog bite, allergic to penicillin, then clindamycin or methoprim, because all of these penetrate the soft tissue. Final. Remember that cephalosporin, ampicillin, amoxicillin, and clindamycin are cause of colitis, because watery diarrhea, abdominal pain, anorexia, and fever. So what you do, the first choice is metronidazole, second choice is metronidazole, and the third choice is minitron. Now you can see that we did not mention metronidazole. And I know many people using it for diarrhea. That is a really disaster. So metronidazole is used for Shigella or Salmonella, amoeba, and gram-negative infection. That's only the indication. We do not need to give metronidazole because it affects the peripheral nerves in a growing baby, unless we seriously need it, even if it's oral. So please avoid oral metronidazole for just diarrhea. Diarrhea are caused by rotavirus. Diarrhea are caused by adenovirus. Diarrhea caused by Salmonella, Shigella, or Brucella. All of them, they don't need antibiotics. Salmonella and Shigella treatment when they are in the blood. Now I will talk about a little bit about how to avoid use antibiotics. So if your unit or your hospital overusing antibiotics, you need to start identify high priority condition. What are these high priority conditions? These high priority conditions, either the antibiotic is not indicated, or they, such as when you have a viral infection, or overdiagnosed, such as streptococcal pharyngitis, or you're using wrong antimicrobial class or agent, or you're using wrong dose. This is a big problem. You start antibiotics, but you don't check the dose. You think you know the dose. Not allowed by law to give antibiotics without checking the dose every time you write the antibiotics. You need to consider the gender, the weight, the age, the renal function, and you need to calculate it. Also, what are the infection? What are the diagnoses? You cannot start antibiotics and saying 5 ml every 3 times or 3 times daily. You also, high priority condition is condition that can be treated by watchful waiting or delaying prescription. Dr. Dell, please. So the high priority, the list of high priority that use is over prescribed, under prescribed, or misprescribed. These are called high priority. So if you want to minimize, and the excuse that we have high sepsis, or we are very common, or we are not a clean unit, these are all being said already, even in United States. So these are not excuses to overuse antibiotics. Remember, when the child is sick, antibiotics will not save the baby. What saves the baby is proper support, not antibiotics. So one of the under-prescribed condition is otitis media and sinusitis. So how also we limit the initiation of antibiotics by doing intervention. And we have 2 types of clinician intervention. So we have to check the barriers. Why a physician antibiotics? Clinic, because want to convince the patient, they come back to you. Fear that baby might deteriorate, and you want to be medico-legally not irresponsible. Think that your baby's, your sepsis are common, and you have no proper care. These are all barriers. You don't have a standard of care. You don't follow the standard of care. You don't practice watchful waiting or delay, because remember, when there is difference between not doing anything and doing watching. There's difference between not doing anything. So when you don't give antibiotics, that does not mean you are not doing anything. So you can delay the antibiotics. Also, let's say you have a 3 months old baby and you think there is infection, just fever, but otherwise the baby is okay. You can send baby home, give something of communication, inform the parent how to follow, and bring the patient next day. Also, use of improper diagnostic testing, and the disaster testing are CRP, ESR, and procalcitonin, and ferritin and other things. We don't use antimicrobial allergy assessment. So baby comes to the clinic, you prescribe antibiotics, go home. You don't do allergy testing, because allergy testing will make sure that your baby will not develop allergy, and you will limit the antibiotics use, because the doctor will not have time to do it and the patient will not have time to do it. So you avoid antibiotics by doing antimicrobial if you make it as a necessity. Now I will pause this. So other intervention are leadership intervention. And so most of time, the clinician have no proper communication skills, have no proper confidence, and they cannot convince the patient, or they don't have time to convince the patient, and they don't have skills to convince the patient, and therefore they prescribe antibiotics because the patient asked them. You also, from the leadership, you can use what we call it decision-making clinical workflow, whether typed, physical, or software virtual. If we enforce the written justification, why you're giving the antibiotics, what is the diagnosis, what is the dose for that diagnosis, what is the bacteria for that diagnosis, then you will also limit the use of antibiotics. The other intervention called tracking and reporting. We give audit and feedback to the doctor prescribing the medication. We use appropriate diagnostic criteria for different diseases. In a special setting, we can use telemedicine, such as you can contact experienced person to help you decide. So we find that with telemedicine, you reduce the unnecessary antibiotics. In emergency, the big problem, because you have to make rapid decision. You have limited diagnostic tools. You have available inappropriate diagnostic tools, such as CRP and ESR and procalcitonin. You don't have pharmacists, or you have pharmacists that not involved, or you don't have clinical pharmacists. All these will lead to overuse of antibiotics. We have intensive care setting. Patient deterioration, big problem. You don't have proper support. You think it's infection. You don't have electronic record to help you. You don't have feedback. You also can consider, when you start, severity and trajectory. Where is it improving? Is it the same or deteriorating? What are the antipathogens that you are giving antibiotics, and what are their anatomical source? And when you document that, and then you write a correct antibiotics choice, a correct dose, a correct duration, a correct spacing, then you will limit antibiotics use. Consider, please, the drug resistance. Consider the host factor, such as allergy, toxicity, immunity. Consider the dosing and route. The route is very important. Should we use prompt antibiotics, or we can delay it? These are all. And tailoring this is not he, this is the. Please, Dr. Hala, mute yourself. So we have to use antimicrobial timeout. Most people using, Dr. Hala, please mute yourself. Dr. Hala. So the time out, you have to limit the antibiotics for 48, 72 hours. If there is no report, so having no report is not an excuse to continue antibiotics, because the yield of blood culture at 48 hours about 95 and at 72 hours about 70. You are rarely culture comes not positive within 7 to be positive later. Please consider IV or oral. Please choose the proper duration to minimize the effectiveness by reading from electronic record. Do not decide on the duration without readings because you think you know. So always when you decide duration, look at the source, look at the antibiotics, and decide the duration. Now you need to select whether you're using narrow spectrum, you know the pathogen, or you don't know, you're using broad spectrum. Now the prophylaxis antibiotics is a big issue, and now especially surgical site infection, and now people are turning to no need to give, for example, you have very clean infection, you didn't touch the bowel, it was an elective section, the site has no infection, then probably no need for prophylaxis. So how we reduce antibiotics? Leadership commitment, accountability, such as removing the license of the doctors who writing antibiotics without necessary, pharmacy experience, action, audit, feedback action, pre-authorization, and we'll talk about it, facility-specific guidelines. So if you have guidelines and you follow the guidelines, then probably you minimize. Tracking, reporting, and education. Staffing, pharmacy. So you need full-time pharmacy for clinical pharmacists to track antibiotics for each 100 beds, and you need special physician for each 400 beds to track the antibiotics. You need antimicrobial oversight committee. So we have two ways, either prospective audit, called prospective audit and feedback, or we have pre-authorization, or we have facility-specific clinical protocol, or electronic clinical decision, or point-of-care intervention by pharmacists, or prescribed-led review antimicrobial. So I don't want to go to details, but these are a difference, the advantage and disadvantage of pre-authorized or prospective audit and feedback way of stewardship or oversighting the use of antibiotics. Each one has an advantage or disadvantage. There is also a lab stewardship program, such as antibiogram monthly or non-culture based diagnostic tools, such as rapid testing, measuring antimicrobial use and cost saving. So these are what also another called process measure. So we have a process measured and process outcome. And I think I should stop here. Thank you very much. And I will be happy to take questions. Was it difficult or was it okay?
It's okay.
Okay. Questions? No questions?
What's Assalamu
alaikum assalam.
What's the appropriate antibiotic for use in neonate with necrotizing enterocolitis, even early stage?
Ampicillin and gentamicin. So it depends. So if you do, you did your screening, rule out sepsis, and then the baby developed neck. So now you have to decide, do you have Lyme or you don't have Lyme? Whether the mother GPS positive or not GPS positive. But if you have culture negative and you did ampicillin and gentamicin and you don't have Lyme and you think you have neck, confirm neck, not just you suspect neck. So you suspect neck, you did culture, and it becomes of overfeeding, not neck. So when we say neck, radiological, And
Yes.
so you have thrombocytopenia, you have hyponatremia, you have leukocytosis or leukopenia, your culture is positive, or you have abdominal distension, you have X-ray finding or ultrasound finding, you have bloody stool, and so you confirm neck or you suspect neck. So it depends. So if you have a line and you have a confirmed or suspected neck, so I think the best choice is aminoglycoside vancomycin. And then you weigh the culture. If the culture is positive, it will tell you which antibiotics to use. If the culture is negative and you suspect neck and you kept the baby NPO, you go for 5 days. If the confirmed neck and culture negative, I go 7 days. With 48 hours culture negative. If culture positive and it's gram positive, I go 14 days with 48 hours culture negative. If it's gram negative, I go 21 days with 48 hours culture negative.
Thank you.
Welcome. Questions?
Assalamu alaikum.
Alaikum assalam wa rahmatullah wa barakatuh.
I have one question regarding inflammatory marker CRP, PCT if high, and then they start antibiotic. Is it the proper choice?
No, they are useless. They are garbage. They are just because the reason why starting antibiotics, because there is no proper support.
Mm-hmm.
And doctors think that antibiotics will save the baby. There is no need to send CRP and the
Especially in cardiac ICU, they just start with the inflammatory markers high, and then they go with the antibiotics. We take them.
No, I don't. Even if it's 100, I will not start antibiotics.
Yeah, like 150 to 100 CRP, procalcitonin is above 0.5, so they just go with the antibiotics.
No, baby symptomatic.
Yeah, sometimes like if they have fever.
If the baby symptomatic, do sepsis workup, start antibiotics. You don't need CRPs.
Okay.
Baby remains symptomatic. Culture is negative. Stop antibiotics.
Okay. Okay, thank you.
But if you stop antibiotics and baby deteriorate, resume antibiotics, do another culture. But the baby, we are saying baby deteriorate with proper support. So baby deteriorate, but you are not giving breathing support. There is no ventilation. This is not deterioration. This is because you are not giving the support. Baby deteriorate because of inappropriate. This is not because of infection. Yes, go ahead, mom.
No, because baby deteriorate and require the positive pressure ventilation, and also like had spike of fever, we repeat the cultures and start antibiotics. Shall we go with the same regime, the one he was on?
So if the baby starts symptomatic, you start antibiotics, you did sepsis workup, you have a proper support. But remember, proper support. You know, you know how to ventilate. Because I would tell you 90% people think they know to ventilate, but they don't know. Yeah, so you know how to ventilate, proper ventilation. Okay, so you're providing proper ventilation. You are providing proper cardiovascular support. You're providing proper nutrition. And you are providing proper sedation and pain control.
Okay.
By then, if the baby is still deteriorating, you might consider culture negative sepsis. And if you consider culture negative sepsis, that's mean there is sepsis, but you think the culture is wrong or didn't pick up. So if you think like this, you give proper support, baby is symptomatic and baby already antibiotics, you continue, and I would decide I'll go for 5 days
or 7
and
days.
I repeat the culture within 48 hours. If the second culture is negative and you give antibiotics for 4 days and the baby is still symptom, the symptom is not related to infection.
Okay, that may be because
you
another
have 2 cultures 48 hours apart, you already give 5 days of antibiotics. Now, if you think, like very imaginary, that there is infection and there is 2 cultures 48 hours apart is not picking up, and the antibiotics that you are giving it is not covering, and then you change the antibiotics, that is nonsense thinking. That is just saying that there is infection on the march, and I will treat it.
Okay.
You're just saying that there is a cow on the moon.
Mm-hmm.
You know,
Okay.
because you said that there is some sign and symptom.
Yes.
And you think these sign and symptoms due to infection, and your culture did not pick it up. And you think the second culture after 48 hours did not pick it up. And 5 days of antibiotics did not treat it. And you need to change antibiotics to save the baby. So 48 hours, the yield of 48 hours is about 95%. The yield of the second one is 95%, giving 5 days of antibiotics. So we're talking about 99.999% there is no infection.
Okay, thank you so much.
If you stop antibiotics and the baby with the proper support, remember, most people say baby deteriorate because improper support, no proper ventilation, no proper sedation, no proper cardiovascular support, no proper nutrition. Baby is not feeding and there is no TPN. And they tell me baby deteriorate. Yes, he will deteriorate. He will have metabolic acidosis. Metabolic acidosis will affect the blood pressure. Baby is in pain and baby will deteriorate, will be desaturating. Baby will fight the ventilator. You will have pneumothorax.
Yes, okay.
Right?
Yes,
so
I get it.
When we talk about deterioration with the proper support and 5 days of antibiotics and 2 culture negatives, 48 hours apart. Now, if the culture is positive, then that's a different story.
Okay, and if we choose, suppose because we have mostly neonates, when they have symptoms and he's on already a proper support of ventilation and cardiovascular wise, pain management, everything is fine. He had fever and we started antibiotics after sending the cultures, all full septic workup. Actually, they are doing full septic
it's a sepsis workup, not septic workup. Okay.
Yeah, sepsis workup. What antibiotics in that scenario we should choose, because they are doing cloxacillin.
So if you do the primary screening and you stop the antibiotics, baby then was asymptomatic and then the baby deteriorate, you need to go for second line. And second line depend, you have central line or no central line, you're ventilated or not ventilated. And you should have, according to your antibioma, you should have a guideline, which is the most common bacteria and what is the resistance. In my unit, the first line is ampicillin gentamicin. The second line is vancomycin gentamicin. The third line is meropenem ampicillin. I rarely go to meropenem because very, very uncommonly, I don't pick up the infection. I don't see what people tell me, gram-negative sepsis. I don't see it very common because 90% deterioration is due to reasons other than infection.
Okay, you mean that
but
if
it's always correct to start antibiotics and sepsis workup, but it's always incorrect to continue after 48 hours culture negative, whether you're doing CRP or not. So anybody in my unit writing CRP, he have to write me a clear email why what we are doing. So when you send CRP, what we are looking for. If the CRP is 100 and baby is asymptomatic, what you're going to do? If the baby is 100 and baby symptomatic and culture negative, what we are going to do? And if you want to continue antibiotics, you are treating what bacteria? And where is the source? They have to answer all that. This is not because you have CRP, I will start antibiotics. But where is the bacteria? Where is the source? It's in the brain, do CSF. Is it in the heart, do echo. Is it in the eye, check, ask for ophthalmology consultation. Is it in the kidney, do urine culture, also for renal ultra. Where is the infection? Not this, the CRP is high. Okay, CRP is high, but where is the infection? What's the source? What is the bacteria? What is the type? For how long you will treat? What is the dose? What is the type of antibiotic you're using and why? Yes. You cannot just say, oh, the baby is fever will cause high CRP without infection. But fever might be due to environmental. You're not giving a, sorry?
And mostly post-surgically, they can have, because of SARS, they can have the CRP high, procalcitonin high.
What type of surgery?
Cardiac surgeries.
Cardiac surgery, no need for antibiotics. Cardiac surgery, absolutely, you don't need antibiotics. Because remember, mom, that you didn't do the surgery in a sewage. Unless You did surgery on endocarditis. That's a
No.
different story. But
Congenital.
if you have congenital heart disease, so
Mostly
you need a
congenital.
prophylaxis to prevent infection.
Usually going for the prophylaxis, but if they have like fever or some deterioration, they will start antibiotics.
Yeah, if you have fever, you do sepsis workup. Culture negative, you stop. As I told you, always correct to start antibiotics, but not to continue antibiotics.
Okay.
If you have a deterioration of a heart, mostly, I find, mostly because of poor nutrition. You got heart surgery and you don't giving amino acid. How will maybe you survive? How will you improve? So yeah, it's a proper support. Yeah. Any more questions?
السلام عليكم.
عليكم السلام. Yes, sir. Tell me.
دكتور عيسى.
دكتور عيسى كيف اخبارك؟ الحمد لله.
جزاك الله خير. الحمد لله. Prof, did you agree that CRP will be raised in case of jaundice, for example? Did you agree on that?
CRP. So the acute phase reactants.
Yeah.
They found it first time when they have the pneumonia caused by Streptococcus pneumoniae. And the acute phase reactant are defined. You should have base level, and the level should change up or down by 25%, above 25% of the baseline level. So the problem with the thinking of CRP. So if you have a level when the baby was not infected, and then you have another level after the baby you think is infected, and the level change more than 25%, then that's called acute phase reactant. And the change can be up or down. And the CRP and ESR and procalcitonin or other type of, such as heptidine or I don't know, I can't remember the list. There are many lists. Some of them can raise, some of them can go low. Some of them they raise with infection, sometimes they go down with infection. Sometimes they raise quickly and they go too quickly. So measuring them make no sense. Now, sometimes they get benefit. I will tell you when. I don't want to mention it because I don't want to convince people to use it. So there are two possibilities that you can get benefit. So you have symptomatic patient and your culture is negative after 48 hours. And you're not sure whether, so what I do if I want to use CRP, I do another culture. I check CRP 3 times. At the second culture, at 12 hours after second culture, and 24 hours after the second culture. If they are rising, I will go with 7 days antibiotics. If they are going down, I will go 5 days antibiotics. So they help me in deciding the duration of antibiotics. This is one. So this is, they can help. But you go serial, you don't go one reading. So you get 120, and then you get 140, and then you get 160. So I go for 7 days. If culture remain negative. If they go 120 and then 80, and then I go 5 days. If I think it's a culture negative sepsis. But I will repeat the second one. The second also negative, and the CRP goes down, I go 5 days. If the second culture is negative, and the baby is still symptomatic, and the CRP is rising, I go for 7 days. And I still keep looking for other causes. And I also think of proper support, especially proper ventilation. Because there is pulmonary hypertension, there is lung hypoplasia, there is TTN, there is RDS, there is central apnea, there is temperature instability, there is electrolyte imbalance, there is skin problem, there is PDA, there is congenital heart disease, there is metabolic problems, there are many reasons why and I'm talking about proper support. You're absolutely good in support. And the most big problem that lead to continuing antibiotics is sedation and pain control. So Dr. Isa, I will give you an example.
Yes, sir.
At midnight, 12, you want to sleep.
Yeah.
And I gave you a call by phone.
Yeah.
Then you try to sleep again, and I called you again at 3 a.m. Then you try to sleep, and I called you 6 a.m. How are you going to function next day?
Very poorly.
You cannot.
Yes, I cannot.
You cannot function. So can you fight the disease?
No.
So one of the most common reason for deterioration of the baby is improper pain control, and we are not allowing the baby to sleep.
True.
So the babies need to sleep 9 to 11 hours a day. Light, noise, procedure, weight. So you need to put, first you need, so in a 24 hours day, the maximum number of touching the baby 4 times a day. If you touch the baby more than 4 times a day, and also the maximum decibel of noise is 70. And then light, especially switching on and switching off. So you have to go dimming or lighting slowly. And you need the percentage of dim to light per 24 hours to be 70%. So 70% of the time for the baby is dim. If you cannot dim the light, there is also a procedure. You cover the baby. And also you put a room for sick baby. So when a baby got sick, don't mix it with normal babies because you keep doing procedure on that baby. And even when the baby is sick, proper sedation and sleeping is very important to fight the disease. So one of the most important that antibiotics and infection being accused of is improper sedation and improper pain control. The other one is proper ventilation. And the other one is not allowing the baby to sleep. Babies die because they don't sleep. Because if I want to torture you, I won't allow you to sleep for 72 hours. You will die. You won't be able to survive. You will die. If I don't allow you to sleep, you will die. So one of the proper reason of death of 23 weeks and 20 weeks is not allowing them to die, to sleep. The other is noise and light, sedation and pain control, proper ventilation. People are very aggressive in ventilation. So how I define Dr. Isa, a neonatologist, is a doctor who can avoid intubation.
Yeah, that is the issue.
That is the neonatologist.
That's true. Yes.
People think that putting the tube, so people think of 2 things.
Yes.
Boluses, antibiotics, put the tube in the baby. That is neonatology.
No, this is the worst. Yeah.
So avoid, Dr. Isa, how many neck I have in the last 12 months?
What is
0.
That? Inshallah.
0. How many culture positive I got? 5 in 12 months.
1 year, mashallah.
How many deaths of infection I have? 1 baby.
Mashallah.
And I go to 23 weeks. How many CRP I orders? 0.
Mashallah.
Yes, Dr. Emerita, tell me.
How many cases per year?
Sorry?
How many cases per year?
How many cases? The delivery, so I have admission about, I don't know, between 250 to 300 patients to an ICU.
It's normal not to have neck. We have 10,000.
10,000 delivery.
Yes.
But how many beds you have?
10,000 per year we have.
No, but how many NICU beds?
NICU beds, 40?
Yeah, so I have 14. But how many doctors you have?
30.
No, it's not normal. It's all about proper use of antibiotics. Of course, you have less patients, but how many doctors you have? I have,
30.
How many consultants you are? So you have 40. But how
we
many
don't have consultants.
But how many doctors in the unit?
30.
30. We are only 5.
30. Yes.
So that's a difference. How many nurses do you have? I have
100.
15 nurses.
We have 100.
Yeah, you have 100
106.
nurses. Yeah, so that's the difference. So with the proper use of, you know,
and
you
it's
have
normal
to have
to have a bigger number of neck or sepsis or.
No, that is not an excuse though. That's the only excuse is improper use of antibiotics and feeding. The neck is high because improper support, improper feeding, improper overuse of antibiotics. It's very well known, Dr. Emerita. The antibiotics overuse is 1, and breast milk. So avoid antibiotics. Breast milk is the only 2 very well known intervention to avoid NAC.
Thank you.
Most welcome. More questions?
Assalamu alaikum.
Alaikum assalam wa rahmatullah.
Doctor, there is evidence-based medicine for using of immunoglobulin for cases of Rh incompatibility?
Yes, yes, yes.
Even without exchange transfusion?
No, we never do exchange transfusion, rarely ever. In the last 10 years, I did it maybe one or none. We never go to that really. Phototherapy, IV fluid, and immunoglobulin should be enough. I never face exchange transfusion in the last 10 years, maybe one time.
Routine.
Sorry? Sorry, what's the
immunoglobulin
question?
as a routine use for Rh incompatibility?
If DCT positive and there is incompatibility, yes.
I mean,
yes. But this is today's antibiotics, not Dr. Muhammad.
Also,
but yes,
but
immunoglobulin is indicated for DCT positive Rh incompatibility.
Excuse me,
the evidence is very
any...
clear. Yeah, go ahead.
DCT positive. Should DCT positive?
Direct cum test.
Yes, yes, yes. But what about late anemia? If the patient develops late anemia, can I give another dose of immunoglobulin or just first dose after delivery?
Anemia due to hemolysis? So you have a continuous hemolysis?
After
so
1 to 2 weeks,
what? Hemolysis?
Late anemia.
Late anemia due to hemolysis?
Yes,
so you
yes.
have evidence
because
of hemolysis?
Yes, yes.
So if there is, usually RH will not continue. If there is a hemolysis anemia, there is other reasons for hemolysis. So immunoglobulin is only 2 doses, but rarely the patient will have no jaundice, just anemia. We can do a talk about jaundice, but this is not the time of jaundice. Sorry, Dr. Muhammad, it's about antibiotics.
Yes, yes.
Okay.
Yes, yes.
Yes, Dr. Ghafran, tell me.
Is there any rule for albumin, IV albumin in jaundice? It's only continuation of...
Albumin? Albumin
yes.
for jaundice? Why?
Yes.
What's the relation between albumin and jaundice?
There's some study.
You give albumin for jaundice, but why? What's
no,
the
I'm not give. But I saw some doctor.
You have hypoalbuminemia?
No, or jaundice due to ABO incompatibility.
So, and the normal albumin?
Is IV albumin?
No, normal protein and serum albumin normal?
I think they didn't check it.
So they give like that?
Yes.
And you think that's correct?
I think it is not correct. So
of course. Why you give albumin to patients? So what about if your sodium normal and I give you sodium? If your potassium is normal and I give you potassium?
Yes, of course. Oh, okay. Thank you.
Something called that makes sense, right? 70% of studies are fake. Remember that.
Okay. Yes.
Dr. Yahya.
Yes, ma'am. Tell me.
About some centers using prophylactic antibiotic if the patient has central line. Are you using this before?
But there is something called antibiotics locking therapy. Are you talking about that?
No, I don't know.
So, do you know what's antibiotics locking therapy?
No.
Okay. So there are 2 ways to do antibiotics locking therapy. If you're continuous infusion, so you give antibiotic window. So what you do, you have a central line and you have a peripheral line. So during that window, you give your medication through peripheral line. And then you calculate how many ml in that central line. And you prime it with a fluid containing antibiotics. You keep it for 4 hours or 2 hours, whatever your window, and then you take it out and then you resume the use of the line. The other way, when you give, there is no continuous infusion, you have central line just for interrupted or scheduled medications, such as antibiotics. So you're giving antibiotics or medication every 6 hours. Between 6 hours, you prime the line with antibiotics, such as gentamicin, called antibiotics locking therapy. But to give antibiotics prophylaxis just because you have Lyme, no, you don't need to that.
Okay.
I think it's been 2 hours, more than 2 hours, and I have to stop here. And if you guys have more questions, you can text me and I will definitely answer the question.
Thank you, Professor.
Thank you very much.
Thank you.
Thank you, everybody. Have a
Very
good night.
informative.
Bye-bye. And there is the
Bye-bye.
presentation will be recorded on the system. Assalamu alaikum, Dr. Isa.